Good afternoon, everyone. My name is Garrett Schmidt. I am the managing editor for ACOExhibitHall.com, and I'd like to welcome you to the first of a three-part webinar series entitled What I Need to Know to Launch or Relaunch a Medicare ACO. Today's session is part one and covers HCC Coding, benchmarks, and spend. A few items of note before we get started. First of all attendees have joined today in listen-only mode, so you don't have to worry about muting your mic. Secondly, we'd like to inform everyone that the webinar is being recorded, so you'll have an opportunity to rewatch the session and or share it with colleagues after its conclusion, and a link to the recording will be emailed to all registrants. Finally, during the webinar, you'll be able to submit questions to our presenter, so feel free to do so, and we will answer as many of those as we can during the allotted time. Those questions are also being recorded, so we will get to yours via email if we're not able to get yours during the allotted time today. Our presenter today is Chris Gates, who is the Chief Executive Officer for Health Endeavors. And without further ado, we'll welcome her now. Welcome, Chris.
Thank you, Garrett. Thank you for hosting this through ACO Exhibit Hall, and welcome everyone. Our webinar today, as Garrett said, is Health Endeavors is presenting the risk score, HCC coding, benchmarks, and spend to get you ready for risk in the Medicare ACO and in other value-based programs. The risk score is extremely important in these programs because it calculates the financial benchmark is what we'll walk through with you. So what is a patient's risk score? So the risk score is a measure of how sick and costly that patient is now or anticipated to be in the future. It is a key factor in value-based programs because it will calculate the financial benchmark. That risk score calculates the financial benchmark. So let's recap a patient's risk score. Every patient has a risk score, and as we take that up the line, every provider has an aggregate risk score, every facility has an aggregate risk score, and every ACO has an aggregate risk score based on the population assigned to them, and correlate that to the financial benchmark. So again, every patient has a financial benchmark, every provider, every facility, and every ACO, and that's calculated using their risk score. The lower the score, the better health of the patient. So the healthiest to the sickest, which is why they call it risk stratification. You're ranking consumers or patients into that stratification. The risk score is based on the patient's demographics and diagnoses. So that's what we're going to walk through next. Other names for risk score, just so you know, RAF is a common reference to the risk score, risk adjustment factor, HCC score, hierarchical condition categories. So you see different names thrown around, but it's more of a calculation methodology than it is the actual name for a risk score. We calculate the risk score using a CMS risk adjustment model. Commercial payers may vary this a little bit by what plan you selected, for example. But today we'll focus on Medicare and how do you calculate the HCC risk score. You calculate it using claims data. The reason for that is in claims data, we get everywhere that patient has been. So whoever has coded a diagnosis for that patient, we get through claims data. Versus EHR data, you only have the encounters for the providers using it. And also it is the payers that will be calculating the benchmark for you, the financial benchmark in a value-based program, not the EHR. So it really matters what has gone to the payers with regard to a risk score and a benchmark. The basics of the HCC risk model has two components. You have the health status, which is the patient's HCC categories calculated with assigned values. And then the second component is the patient's demographic characteristics. So the risk score basic formula is equal to the demographic score plus what they call the health status or HCC score based on the values assigned to those HCC categories. HCC categories, there's around 70 of them, and they are to measure the disease burden. So Medicare wants to know how many dollars should I book next year to pay for a population. So they take the risk score and they extrapolate that out to dollars. Every risk category has a value assigned to it, and then they want to extrapolate that out to say, this is how much that should be spent on this patient. ICD-10 diagnosis codes are assigned to HCC categories. So for those 70-some categories, they will have multiple ICD-10 diagnosis codes in those categories. And those will each have an assigned value, the HCC category, and they're added up to come up with the health status risk score. You can go out and you can look at different references about the ICD-10s, but basically the ICD-10 diagnosis codes are assigned to HCC categories. And if you go out on this link, you can see all the different ICD-10 categories correlated to their different HCC categories. Each category, again, has an assigned value. You add up all those values to get to your health status score. Now, some HCCs override other ones, so they're called duplicate categories is the best way to describe them. Sometimes you could have, for the example we have HCC category X, may have 10 ICD-10 codes in it. It's a priority over HCC category Y, which has 8 ICD-10 codes in there, and these two may overlap in diagnosis codes. But one of them, HCC category X, is the priority, so it will take the value for the priority category. HCC categories have different values assigned to them. Some are much higher because the associated cost of caring for that condition is higher. So here's a list of a few ones you would expect: diabetes, congestive heart failure, that have higher values assigned to them because they will spend more on these patients to care for them. Remember, the risk score calculates the benchmark, financial benchmark. So our first component is the health status, which are the HCC categories with ICD-10 codes assigned to those categories. Then we have our demographic factors. So again, you've got your raw risk score, you've got your health status, which is the diagnosis is assigned to HCC categories, and then we have our demographic score: age, gender, your disabled status, if any, original reason for entitlement, and are you Medicaid eligible. So if you look at the two components, as we'll talk about in a little bit, which one do you have control over? And it is the diagnoses. So to recap the calculation, we have ICD-10 diagnosis codes assigned to an HCC category. Each category has an assigned value. You add up the values for the HCC categories. Yes, you'll have some eliminated because they get overridden by other categories, but you add up the remaining HCC categories and their assigned values, and that is your health status score. And you add that to the demographic score, and that is your HCC risk score. So again, what is in your control? You can't influence the age, gender, the reason for eligibility. You can't influence any of that. But what you can influence is the diagnosis. So let's talk a little bit. Why does it matter so much that the risk score is accurate? If the risk score is not accurate, this is the most important reason, then the financial benchmark is not accurate. So if it's not accurate for 10 of your 20 practices in your ACO, then your ACO benchmark and financial benchmark and your overall risk score is not correct as well, because that HCC score is what is used to calculate your financial benchmark. So let's look at this example here of, let's say we had actual spend of $13,000, and let's say this was the wrong risk score and it was set at 10,000, that the benchmark was set at 10,000 based on the associated risk score. So pretty much no matter what you do in this, if you are at 10,000 and it's wrong, you're not going to be able to get your spend under that amount. So let's say the correct benchmark should have been 15,000 per patient per year. So this is the right risk score extrapolated out to the financial benchmark, and your actual spend is still the 13,000. Then you have an opportunity to achieve shared savings. We put our Pathways to Success planning matrix in here so that you could click on that and you can start playing around with some of the different scenarios. If you had the right benchmark, what would be my risk in this program, or each one of the glide paths that you choose? So again, the financial benchmark calculated using the risk score, and it's for across the board, all payers, ACOs, facilities, individuals. It's the same methodology in general for all of these different payers and individuals. So let's look at some scenarios that impact HCC failure to code a diagnosis. So this patient has a decreased score. So what the score should have been, if everything was coded, is this top line. This risk score should have been 1.973, resulting in a $17,856 annual benchmark. This is what's projected that this patient should spend based on their risk score. What wasn't coded, though, of this patient during the year of this calculation up above here, we had 2 HCC categories not coded. The diagnoses were not coded. So that lowers their score and the associated benchmark. So by not coding those two, it went from 17,856 to 10,064 for a benchmark. Let's look at an increased score. So let's say we started with this score of the 1.062 for the risk score, which equates to a 9,611 expected benchmark or annual expenditure. But let's say we were doing our due diligence and we were going through every patient as they come in, and we were making sure we coded all of their diagnoses, especially the HCC diagnoses. And we added these 3 codes. That brings the risk score up to 1.86. And we're adding these obviously because these are applicable to this patient. That results in a higher benchmark. So you've gone from 9,611 to 16,833. So let's talk a little bit about, so let's go beyond an individual patient and let's look at some risk score and benchmark analytics. So you want to calculate the risk score and the financial benchmark at all levels of your organization, so you can start seeing your trends, start seeing where the, who's headed into above their benchmark, because everyone has a different benchmark. Every patient, every provider, every facility. So let's start with what we call our executive dash. Let's just go to a little bit bigger view of this. I'll make it a little bit bigger. So as I go across this patient on the top here, you'll see that, let's go up one more here. You'll see that their average risk score is 0.445. It's down 70% from last year. That means, this is an exaggerated example, but that means a lot of diagnoses have been removed. Because remember, demographics isn't in your control, only diagnoses, and that will bring down the risk score and associated benchmark. Good news is you haven't spent much of those dollars. So let me flip to a 2018 example, go back, for which we'll obviously have more data. So this is a risk score in 2018 of 1.5 around. It again has come down 17.54%. The benchmark based on this risk score is 13,559. The actual spend is 15,192. It has exceeded its benchmark by 12.04%. So you have used 112% of what was allocated to you. So you're above, you're overspending on that patient. So, or on the patients assigned to this provider. So I'm looking at it a view, you can go from NPI to subgroup, which would be groupings of locations underneath a TIN, and then you can have your facility view. So if I go down to the next patient, lower benchmark, 0.897, again, it's gone down 20%, which means diagnoses are falling off. Then you have your benchmark, associated benchmark to this risk score. But on this one, we've only spent 83%, or $6,786 of the benchmark of 8,118. So that's how you extrapolate it out beyond the patient. But you also have to pay attention to the individual patient. You have to also look at their risk score and what have they has been spent on that patient. So if we look across at this Willie test patient here, you'll see that in red, 118.93%. So any patient in this mix that's in red is telling you they're exceeding their benchmark or will soon exceed their benchmark. Once we get your risk score correct, you want to go beyond the basics of diagnoses, but that's the subject of probably another webinar. You start mixing in things like potentially costly algorithms. We use, they've had admits, ED visits, they're not taking their medications, they've got 3 or more chronic conditions. So you can start modifying your risk score and adding more factors in it to stratify your population even more. And then you could also start adding in patient-generated data such as a family health history to get into more predictive benchmarks going forward. And that would be your potentially costly, those that you're predicting in the future to exceed their benchmark. So let's talk about diagnosis accuracy strategies. So what can you do to get a better benchmark? What is in your control? The diagnosis, right? For it to be successful, the financial benchmark and risk score, the provider team must report all diagnoses that impact the patient's care. So again, here's an example of how a diagnosis, how documentation and the actual what was remitted for this patient affects the scoring. So the true diagnosis is on the right, the wrong diagnosis is on the left. And that resulted in a risk score of 0.162 for the wrong diagnosis, whereas if it had been coded properly, it would result in a 0.511 for the risk score. So you've lost some risk score here. This one's lower, which means the financial benchmark for this patient will not be correct. It will be lower than what it should be. So the key is to be specific. We'll talk about MEET, the common standard for documentation, a little bit, but the provider team must be very specific and document all active chronic conditions as well as conditions that are relevant to the patient's current care. And then once you document and code those, you must manage them. They use MEET for all chronic and relevant diagnoses. Monitor, evaluate, assess, treat. So if they want you to follow each one of those for every diagnosis that is chronic, an HCC diagnosis for sure, and relevant diagnoses to their care. One of the biggest issues that comes up with the score is the codes don't get to the payer for a variety of different reasons. So over 50% of ACOs we have talked to and surveyed have encountered this issue. They may put on their, I call it super bill, which is probably old school language for it, but when they're seeing the patient and they're coding it, they code 4 diagnoses. But when the billing company goes to submit it, either the billing company, the EHR, whoever you're using, they only need 2 codes to get paid. So they only submit 2 of the 4 HCC codes. And what does that do? It results in a lower risk score for the patient, and it results in a lower benchmark for the patient. So not capturing all those codes, again, if they're not sent to the payer, especially Medicare, it's not going to get calculated into your risk score. Now we hear lots of questions about, well, we can't send any more than this number of diagnoses through our system. Then you need to go talk to your whoever, your EHR, your billing company, and you need to let them know, I need to send a minimum of 4. I would like to send up to 10 to 12. How do we make this work in our system? Let's talk a little bit about EHR strategy. We have talked to lots of providers in ACOs and other value-based programs, and most of them have a common theme of, I don't really know when a patient comes in, are they in the ACO? What's their benchmark? What's their risk score? Have they spent more than what's been allocated to them? I don't have any idea. So let's start talking about bringing actionable data as one of your strategies to the provider team. So the first step is when a patient, let's say I'm the patient, I come in, Chris comes in to see the doctor. I'm a Medicare patient. The doctor will go in and call me up in their EHR, and what they should have in front of them is this patient above or below their expected spend based on their benchmark? And what is their benchmark? Is it poor or good? So the provider team will instantly know if the patient is above their benchmark by the red bar. So after 12 months, the diagnosis is removed unless it's recoded. So let's go to the next. screen. So at the point of care, the same thing in the EHR, patient comes in, patient Michelle comes in. You see right away, this patient is above their expected spend. Then let's go down to their HCC diagnoses. What has been removed as compared to last year? Because I want to make sure I recode any diagnosis that has been removed. This diabetes with complication is crossed out, which means it's been removed. If I don't recode it, it will not count towards the risk score. So the risk score, again, will therefore be lower, and the financial benchmark for this patient, lower. What other actionable data can we bring to the provider without overwhelming them in addition to this spend? We can bring to them how much they're over, right? Follow the red. They're at 101% of their spend. They haven't had a wellness visit. They've had an admit. They've had an ED visit, ED that led to hospitalization, CT scans in the 2 in the last 12 months. Most things, such as admits, ED visits, the primary care provider doesn't know about unless there's a really, really good ADT system. But most providers, from what we have found, do not act upon those alerts timely enough. They don't get them timely enough to be able to act on them, I guess is a better way to put it. So let's bring it to the provider and say, okay, this patient's above their spend. Let's start talking to them. Why did you go to the ED? Why did you have an admit? And Medicare has said in their last analytics they put out 50% of ED visits for Medicare, around 50% is due to medication. So is it a medication management issue? Quality metrics, again, let's tell them in order to get the score correct and, manage the person, let's make sure all those quality measures are done. So anything with an action required means nothing's been recorded for that quality measure. Same with care gaps for disease and wellness. Is the wellness visit done? What are their diagnoses and what are their associated care gaps? Follow the red. Further down the line, you might want to start thinking about out-of-network. I would do the other strategies first, such as making sure every diagnosis got coded and recoded and bring to the point of care the actual spend of the patient. Out-of-network matters because you're responsible for that spend in the value-based program, and they may or may not be being managed according to your protocols when they go out of network. So how does it work to send data to an EHR using an application program interface? Every EHR has an API that is certified. So what we do is we go into their sandbox, we get approved, and then they will start signing up practices based on bulk at a time. You got 20 practices, they're all on eClinicalWorks. Now we're going to listen to you and we're going to get the API going for those. And then we'll come back to the next batch. So what happens in an API is a provider team opens the patient record in the EHR. A patient match with our repository then occurs. Does Health Endeavors have any ACO data or any Medicare Blue Button data for this patient to render the cost, utilization, etc.? If yes, it will render in the EHR. And at the same time, we can pull clinical data out for quality metric reporting. You can also, if you can't get your EHR set up or it's taking time, you can just run a simple patient search. So I can just go here and type in Willie and I can run a search to find that patient's, where are they at? Quick and easy when the patient's coming in for a visit, so that you know if they have a red bar, and look at all these diagnoses that will be removed. They are all crossed off. These are all HCC diagnoses. And they will be removed unless recoded, which will result in, again, as we've said multiple times, a lower risk score and a lower financial benchmark. So why is the annual wellness visit so important in this? A lot of people have said, well, you've got to do it for care. You've got to get them in for their quality measures. Yes, that's all true. But another reason it matters is if you don't recode that diagnosis every year, it will be removed. So we want you to do that HCC coding at the point of care. Look to see what has been removed for a patient, recode it if it's applicable to the patient, and then apply your MEAT or other management protocols to manage that patient's diagnosis. Changes will take 12 months to take full impact. If you're robustly attacking your population to get that score correct, the diagnosis is correct, it will still take about 12 months. So don't wait to get started. If you're heading into any value-based program, any risk program, you need to start today. So what are some of our quick wins? Schedule the annual wellness visit, because that's where you can apply your care protocols of managing a disease. You can code applicable diagnoses accurately. You can do your HCC coding at the point of care, recode those that are going to be removed, because if you don't, they will fall off. Capture the HCC diagnosis code with the payer. So verify that these diagnoses are all being sent. And then analyze your claims data. Like we were showing you, get your data into a repository so that you can have a dashboard of where does everybody stand today, who's already going to exceed or we're predicting will exceed their benchmark as a provider, as a facility, as an ACO, as an individual patient. Now, just going back to this capturing the HCC diagnosis, we get lots of questions around this. You need about the diagnosis is not going through. Oh, we can only send 2. Well, you need to get with your billing people to work out, how do I send at least 4, and how do I send more, 10 to 12? What is the process for sending more diagnosis codes? And at the very minimum, if you can only send 4, then send 4 of the HCC diagnoses. Don't send 4 diagnoses that aren't HCC diagnoses, because not every diagnosis is an HCC diagnosis. You can also do report strategies, which we're working and playing with these every day. Patients not taking medication. So this is more about management, making sure they're managing, but also trying to search out, should there be a diagnosis there that isn't there? Such as, okay, so let's say you have a medication, but no diagnosis. So the diagnosis is what matters, right? That's what raises the risk score and the benchmark. Or a diagnosis, but no medication. That means the diagnosis most likely isn't being managed. You can also do an HCC coding and external audit. That's a long-term strategy. I think start with some of those quicker wins that we were talking about, and then move into who am I going to join up with in order to do and keep an ongoing external audit to keep us on track. So we talked about the risk score not being accurate. Let's say your risk scores are now accurate. You've done a lot of work to get them accurate. Your new problem is you need to manage those conditions. You can't have the patient going to the room or emergency room, getting readmitted, because then that patient will exceed the spend allocated for that patient. So the actual cost of the coded diagnoses exceeds expended level for that HCC score. Remember, every HCC category has a value assigned to it as to how much spend should happen for this diagnosis. What would we anticipate for a patient with diabetes without complications? What would we project the spend to be? That's what the HCC diagnosis is doing. If the patient spends more or you spend more in your program due to not managing a patient going to the emergency room and readmission, you're going to exceed that level no matter what. So you have to get the score right, and then you have to manage the patient to keep within that allocated spend. And a lot of people, again, use use that process to manage their patients. But you must document and must manage the diagnosis. They go hand in hand. Let's talk a little bit about consumer engagement. How do we get the consumer engaged in this process? What about offering incentives to improve a score, such as do a modified score for them, My Health Score? So let's say a patient starts with a specific score. Let's go take a look at where they started here for this patient. Let's say their HCC score was poor, but through incentives with the person, we moved it to excellent because what are they doing? They're managing their condition. So what things can we do to incentivize that person? First, we can populate all their diagnoses and say, categorize the diagnoses so we know where you're at on an in-mass level. Either yourself or a family member go through and say, we're unaware of this, not managing, management not required. So across the board, you can get feedback on every single diagnosis assigned to a patient. If they're not aware of it, they're not managing it, right? So let's get them aware of it and get them moved into the managing. You want everybody in the managing area, or you want to remove the diagnosis if it's not applicable to that patient. So give them points for going through their diagnoses and then their medications, yes taking or no not taking. So you could give them a certain percentage in our algorithm for completing this form. You could then give them a certain percentage for doing their things to complete. Okay, so we'll go back to our slide deck. So they've got a score. We're going to incentivize them to go through all their diagnoses. Make sure you're aware of this. It's in your data. That means it's assigned to you. We then put data into two buckets: incomplete care gaps, send a text alert to the consumer. Complete care gap, that goes into the quality measure reporting registry to answer the measure. So here's an example on the phone of the care gap text alerts. They get a text alert telling them they have things to complete. And then if they go in and complete these items, coordinate with their primary care provider to get their disease, wellness, and quality care gaps completed, then their score could come down again. So we're doing a modified score to incentivize the consumer with immediate reward and something they can track with progress. They do this every month. We're going to keep their My Health score at a better score, and doing other things such as your care plan, Fitbit goals perhaps. So you can do all kinds of things to incentivize the consumer. So those care gap text alerts, we talked about two buckets. Okay, so anything in the red or the gray, non-performance or incomplete, they're going to get a text alert to push them to come back in. Get that done, get that done. And if you have it at your point of care, your data, you're going to see those same care gaps for that patient. So that your gap analysis should start improving as you address those when they come into the office and as the patient gets the text alert and comes in, which would in turn improve your scores, your performance scores for each measure. What are some other Launch Your ACO resources? We urge you to go back to the Pathways webinar that we did a few months ago and the Pathways Planning Matrix. If you need any of the materials from these, let us know so that you can start planning what risk can I assume once I get a benchmark that is correct. ACO Exhibit Hall is promoting the three-part series, so you've got next Friday the 12th and the 19th for 2 more sessions. There's an ACO Direct Contracting Symposium, May 2nd and 3rd in Kansas City, and there's other conferences going on as well. We just think this is a great way, if you did direct contracting with self-insured employers, to diversify your ACO and add another population. And then ACO Exhibit Hall is hosting a Get the Right Benchmark to expand on what we talked about today, and Join is going to be joining us to talk more about doing audits and to fast-track coding fixes. If you want to get your analytics that we showed you today, I want to see what we look like when we go to this executive dash tool. I want to see where everybody looks. Let us know. We've signed hundreds of DUAs with people to do this for them, and we will analyze your data for 48 hours and give you access to it. So if you want to do something like that, then get a hold of Adam, and he will get you set up. In 48 hours, you will know where everybody's at with regard to their benchmark for this year and last year. And I'll hand it back over to Garrett. Thank you for hosting this, and I'll let you go ahead and wrap up with any questions we might have.
Okay, great. Thank you, Chris. That was a wonderful presentation. We actually did have quite a few questions come through, so we'll try to get through as many of these as we can. And these are in no particular order. The first question is, Chris said the codes disappear after 12 months, or is that really in reality, it is just, it has to be in this program year? In other words, can we think of the codes as disappearing on January 1st?
You could think of them in that way because it is ultimately a calendar year, but if you drop codes off that would still be considered in your risk score on a calendar basis, then you're going to skew your results a little bit. So we keep carrying those over so that you can get somewhat of a predictive score. But ultimately, this is why your shared savings isn't paid until September, because Medicare is going to, in 2019 in September, look back at 2018 calendar year, you're correct, to say, were you above or below your benchmark based on the diagnoses in that calendar year. So it is correct, it's a calendar for the final reconciliation. Okay,
great. Second question, is it true that the payers only look at the first 4 diagnoses in a claim?
Not all payers. So we need to say, let's look at your commercial. Most commercials, you go talk to them, they'll start accepting 8 to 10, and make sure those 8 to 10 are HCC diagnoses. Now Medicare has 4 diagnosis codes that can go on a service line, but you can code and include up to 12 diagnoses using supplemental ways. You need to get with your payer to figure out how do we submit, 12 if there are 12. But no matter what, if you only submit 4, make sure it's the HCC diagnosis codes, because many of you are submitting codes that are not HCC diagnosis codes when there is one that exists in your clinical data.
Okay, great. And then to confirm, the RAF score uses one ICD-10 from a category, but a beneficiary can be in multiple categories, and each category contributes to the final RAF score?
So multiple diagnoses can be put into an HCC category. So an HCC category can have 5 diagnoses, 10, 20, and they can overlap. So one category could override another category, but multiple diagnoses can be put into an HCC category. When we get to the end, we take all the diagnoses that have been correlated to a category, and we add up the HCC categories to come to the score. But some categories will be eliminated because the patient fell into another category based on a different diagnosis or the same diagnosis.
Okay, great. Next question, does Health Endeavors have a preferred API?
We don't have a preferred API. What we have to use is the EHR's API. So every EHR has what they call a sandbox or a store. So we go out to Allscripts store, for example, or their sandbox. We register for that sandbox, and we pull down their API, how they want it to be done, and we comply with their API. So it's EHR by EHR, how we have to connect the data back to the EHR.
Okay. Here's a question. What if a patient doesn't have a primary doctor and won't schedule an annual visit?
Well, that's up to the provider. You need to get that patient in, though, right? Or you're not going to be able to recode the diagnosis. So if a patient goes 2 years without seeing you, it maybe goes to the urgent care, a few things might be coded, but you're not going to have a mechanized way. So you need to figure out how do I get access to that patient? How do I get better access? Why won't they come in? Is it that it's not convenient hours? Is it they don't have transportation? Can I bring the service to them in a way? There's lots of companies bringing the annual wellness visits to the consumer in a closer setting to where they're at. So you need to start looking at ways to get that population in. It's very important.
Okay, and along with that, what about patients that refuse care management?
I think that, again, you have to start working on your skills, customer service skills, and impressing upon that patient the importance of them being engaged in their care. Use the incentives of the score. If you do these certain things, your score will go down. It's been proven that positive reinforcement with a patient works. You give them immediate rewards, and you give them something to progress towards. So while you're going to have some patients that fall out that never will comply, you'll have other patients that there's things you can do with them or with their family to get them to be more compliant.
Okay, great. Next question. Is the blue button data comparable to the CCLF?
Yes, the Medicare Blue Button is comparable to the Medicare ACO data. Medicare Blue Button data is a little bit better because it comes every 7 days. It syncs every 7 days, so it's a little bit more recent than the monthly ACO data.
Okay, and the last question is, could you clarify in how you define potentially costly?
We use a variety of different algorithms, so we have different levels, but for the one on our main dashboard, we use a combination of what is their risk score, how high is their risk score, have they had a readmit, have they had to a hospital, have they had an ED visit, what medications are they taking, are they not filling those medications? So it's a variety of different factors to say that person's costly today, and we're predicting they're going to exceed their benchmark.
All right, great. Well, that concludes our Q&A for the episode here. So thank you again, Chris, and thank you for that presentation. Any additional questions will be answered via email. And also, if you have any specific questions for Ms. Gates, her contact information is here on the slide. And feel free to make a note of that and contact her directly, and she'll be happy to follow up with you for further discussion. Lastly, be sure to visit Health Endeavor's exhibit booth on acoexhibithall.com and learn more about them and connect with their team, and you can do a deeper dive there. And that concludes our webinar for today. Thank you for attending, and I hope you found this presentation helpful and informative, and we hope to see you at part 2 next Friday. Thank you, and have a great rest of your day.